Yep, you're all set.
I'll just let you know when the share screen comes on, it'll look like a tsunami, but just remember, I want you to know I have everything under control. All right, so can you see this?
Yes.
Good deal. Oops, oh, sorry. Let me go back. So good to see everybody. Wow, this is a big group. And I gotta tell you, I was just telling Ellen, why did she ask me to talk about this? And I said, well, one of the things that I know that when I do research for a talk, I do as much as I can, and I'm always so appreciative of everything I've learned. So this talk was something that is something that I deal with regularly with clients, with family, something that I want to talk to students about who are working with persons who have dementia and depression and delirium. So it came out a good time, but it's also a very hard topic. Um, a lot of the things that we're going to talk about, I will tell you that I am still learning. Full disclosure, I'm learning about this as I've been researching it. Um, but I'm also not a doctor. So I am very careful to tell you that I am sharing with you what I've learned. I hope that I'll be able to give you some really good resources, information about what I've learned, but also have at the end, I have some resources, some tests and scales that might be used. And I also I have a case review. One of the things I want to tell you about the PowerPoints is I'm not good at checking on chat and doing the PowerPoint. So I ask people to keep their questions until the end. And a lot of the PowerPoints I will move through if we're moving slow because I'm terrible with time. And I put all the PowerPoints there and I don't always use them. I change them around depending on the population and depending on the group that I'm talking to. So don't worry if you don't see it, it will be in the handout. I'm putting together a handout that'll be much more concise. And now the handout will not have all the pictures. It will just have the information. So when you get that, say, well, that doesn't look like the handout. Well, I take the pictures out so it's not so heavy. So let's go ahead and begin. Today we're going to talk about depression, dementia, delirium. We'll talk about what it looks like to us, the layperson, what the clinicians, professionals describe it as. We're going to look at how it's different from each one is different from each other. How will you know? Well, this is the hardest part, right? How will I know? Because there's so much overlap. But I've put together some charts that will give you at least some structure that will say, well, this is a little bit different. And again, I'm not a doctor, right? And I'm not going to make you a doctor. I'm not a nurse, but I am a family member with people who have had dementia, and I have worked with many families. And I know that just having more information and education gives them some confidence saying, okay, I know this is something I might know a little bit about it. I'm not an expert, but now I can ask the doctor. And now I can ask him for some more information about this. And let's all agree that the situation with healthcare right now is that everybody is overwhelmed. Facilities are very busy. And it's possible that things get missed. I'm not blaming anybody, but it's possible that something like that can happen. And if you, as a family member or as a caregiver, as a loved one, are engaged, this might be something that you, as a team member, might be able to bring up to them if you're aware of it, just to ask about this as a possibility. Okay. Like I said, I am fully aware that I am not a doctor. But I am aware of the reality. Okay. The reality is that 50% of the cases of depression go undiagnosed. The reality is that in dementia, 75% of all dementia cases go undiagnosed across the globe and up to 90% in lower to middle income communities. The reality is that in delirium, it affects between 18 and 35% of persons admitted to hospitals, and up to 60% of people in ICU, they might experience delirium. So this Cleveland Clinic has shown us research that says that between 1 in 3 and 2 in 3 delirium cases go undiagnosed. And when you consider a syndrome such as delirium, an illness that can have such profound effects on the person's health, mobility, and functioning if it's not diagnosed and afterwards. This is a very important thing for everybody to learn about who has a loved one that has dementia. The chart on the right is from Dementia Learning, which is a Australian. I really get a chance to look at all. UK has some great depression, dementia, delirium. Australia has some really good information as well. But one of the things that I found stunning and concerning was that in their research, they found that 1/3 of staff are not confident about delirium. We know in the United States that there are delirium protocols, there are steps to take, but it's also helpful for us to know what it is and what they are. So what, as family members, we can be assured ourselves that we are familiar with what should be done, what we can ask about, and what we can do to make sure our loved ones are taken care of. I can't not talk about suicide. This is Suicide Awareness Month. And the reality is, older adults who and this is their words, because we don't use the word commit suicide anymore. We have somebody who has, who has killed themselves, who has suicided, but commit suicide is what we consider is like a blaming. So we don't really say this is their words. And they say that a person has visited a primary care physician and very close to the time of suicide. Whoops. In some cases, 20% on the same day. In some cases, 40% within 1 week of having seen that PCP, and 70% within 1 month. And these also are very concerning. Us, again, being aware, Suicide Awareness Month, and how that our clients who have depression, dementia, and delirium could be at risk for this. So let's talk about what depression looks to us, the layperson. People would describe it as this. I do education for constituents of organizations and also for staff. And for the layperson, for the people that we're working with a lot, they say it's an empty feeling. So what is this? It's an empty feeling. Apathy. They have a loss of interest or pleasure in activities. And they have sleep problems. Usually with depression, it's early morning wakefulness, but that's a generality. It's different for everybody. Irritability, trouble focusing, remembering, or making decisions. And it's that last one that really has some overlap with some of the other things we're talking about today, right? Depression with dementia and delirium. So let's look at now, how do these, I wanted to say, the ones that we're most concerned about, feelings of worthlessness, guilt, hopelessness, or helplessness, and recurrent thoughts of death or suicide. These are the ones that will really cue us, are the red flag that we may pay a lot of attention, that we need to pay a lot of attention to. So depression diagnosis, according to the DSMs, those of you professionals, there are many professionals here, and there are some family members, maybe you're not familiar with the term, it's a diagnostic and statistical manual, and it's, we call it the Bible for healthcare providers, and it gives them a chance to have a common language so that everybody is using the same language. Very important. It gives criteria, but also know that as we're talking to family members, they may not be using this language. They use language that we just talked about. So always remember that these are the situations that we need to keep the DSM aware. We're aware of it. This is how we diagnose professionally. But as we're listening to family members, the way they explain it to us will depend on many different things, including cultural. So here is what it looks like according to the DSM. This will be in your handout, so I'm not going to spend a lot of time on it, but I want you to have a basic idea. Also, again, remember, most important things, feeling worthless, guilty, and hopeless. Think about death and dying. These are the things that will require our immediate attention. We talked a little bit about, depending on a person's cultural background. Those of you that work in agencies, you are probably recognize that with African Americans and Hispanics and Asian persons, that this will look different depending on how they express their emotions. So how they are giving these signs will require us to be a lot more in tune about their cultural background. So let's talk about some factors that predispose older persons to depression. And one of the things that we know is that at this point in their life, if persons have maybe not had some protectors of aging, what we call factors that will give them some resilience. It's very possible they may have had a lack of, that they may now have a lack of independence. It's possible that they've had loss of spouse and friends. They've lost some connections because of retirement, loss of health. This predisposes them to depression, but also financial uncertainty, and especially loss of family connection. And something that's very important that I'm paying a lot more attention to, that's also become much more prevalent, is estrangement from family. And unfortunately, this is something that's become prevalent, a lot more, happening a lot more. And that's another whole presentation about what this causes for older adults. So what are some risk factors? Well, obviously life changes, trauma or stress, elder abuse, isolation, physical illness and medications. And this is where we want to talk about what are the medical issues that might be going on that can cause depression. I'm going through this real quick because remember, we're going through depression, dementia, delirium, and this will be in your handouts. So some of the medical conditions: Parkinson's, you see here, diabetes, lupus, MS, heart disease. But look at here, dementia and Alzheimer's disease. Dementia, of course, is what we use as the umbrella term for many illnesses, and we'll be looking at that shortly. But again, I want to tell you that at risk, those that we worry the most about, and this is what we call the 4Ds, creating risk for suicide, and this is by Dr. Yates Conwillis, and he looked at 4 areas that increase the risk for suicide. One of the areas, of course, is depression, what we're talking about now. Debility, what we're talking about now, persons that have a debility due to a medical condition or a mental health condition. Disconnectedness, isolation, being estranged from families or friends, and also, most important, especially in the community where we live, with firearms, is deadly means. Now, there has also been a lot more studies about the associative diagnosis of dementia and suicide. In a recent study, Yale study, that they reported that one of the largest studies is like 594,674 persons were involved in this study. And the outcome of the study said that that those diagnosed before ages 65 were especially at risk for suicide. Those also at risk were those who were diagnosed, who were in the first 3 months of the diagnosis. And then third, those with known psychiatric comorbidities. So recognizing what a fear of the diagnosis of dementia could create for people, these are some things, again, to be aware of, especially as we're learning more and more and have even more of awareness today during this month of suicide. And let's remember this going on. So there are a lot of forms of treatment for depression. It's very treatable. One of the things that keep us and our loved ones from seeking treatment sometimes is the ageist view that an older person who has depression, that this is a normal condition for them. And this, we know now through research, is not the situation. Depression is not normal, dementia is not normal, and delirium is not normal. And each of those have to be treated. And some of the ways that depression can be treated is through psychotherapy. Those of us who are in the profession, talk therapy. Some of the modalities that we don't consider because we often associate them with other cohorts. When we think about depression, a lot of times we leave out the age group of older adults because we don't associate it as something that they can benefit from. That we don't think of them being able to benefit from individual therapy, CBT, interpersonal therapy, and group therapy. Yet the research is showing that certainly older adults do benefit from this. And even those who have dementia benefit from it. When we think about dementia, sometimes when people are saying, well, the person has dementia, are they going to benefit from it? We have to remind them, dementia is a very wide scope. Just because you have a diagnosis of dementia doesn't mean that they automatically are at the most severe of dementia. So let's recognize that everybody can benefit from this. Of course, medications, ECT, and even TMS. So here we go, the dementia umbrella form, but really we know that the Alzheimer's disease is the most common form of dementia and contributes to 60 to 70% of cases. We used to have this dementia umbrella and it was not as large. And now when you see, it was just like a signature, dementia, and you would often see right away all the things that came under it. And so now we're realizing that there's more and more illnesses that have some of the clinical effects and criteria for dementia. So we're talking about dementia, but let's talk about what the DSM, remember, is in its fifth revision. And so one of the changes that has been done is that they don't use the term dementia. It's still acceptable, but what I'm understanding is the term dementia, because of its stigma, was one of the reasons that they changed the term. And so now they refer to either minor neurocognitive disorder, and that might be what we call prodromal disease, or what we also call MCI, mild cognitive disorder. So you can see the mild neurocognitive disorder and the major neurocognitive disorder. Mild, of course, is there some evidence, but the person is still, the cognitive deficits they're not really insufficient. The person's still able to be independent. That changes in major neurocognitive disorder. You can see that now the cognitive deficits, they are sufficient to interfere with independence. They start requiring more assistance and more help with the instruments of the IADLs. So what do we and what do persons in the community, lay persons, now what for them are the signs and symptoms? I know that Alzheimer's Association and Alzheimer's Services, they use the basic 10, but here's a way for you to see it from the NIA, some basic signs and symptoms of dementia. I'll let you read that. Memory loss, repeating questions, taking unusual words to refer to familiar objects. It can be hallucinating or experiencing delusions or paranoia, certainly depending on the form of dementia. It can be acting impulsively, and it can also affect balance and problems with movement. So this is what dementia looks like to the layperson. You've seen the DSM earlier, what the professionals and persons in healthcare use as their diagnostic criteria. What are the risk factors? Well, age, of course, this happens more often with older adults. The biggest risk factor is age. It's rare in persons who are younger than 60, but it becomes more common, especially in persons who are older than 80. We know that another risk factor is family history. Some forms have a genetic component, meaning that it runs in families. Another one's persons who have Down syndrome. And now, due to the work of Rebecca Levy, we're learning more and more that a negative view of aging could predispose you to dementia. This has been something very important to me because I do a lot of studies talk about ageism and seeing how we can prevent older age diseases, premature death, and now we can also associate it with dementia risk factors. So to the right, you'll see some of the known risks for Alzheimer's. Of course, these are things that we're trying to educate everybody about, because some of these are things that we can take into our own hands, that we can change for ourselves. For example, exercise, not smoking, not using excessive alcohol use, watching obesity, hypertension, depression, and hearing loss. So what now are some of the differences between depression and dementia? So this is a way for you to kind of have an idea about, okay, so that's depression and dementia. So let's look at the differences. Well, you see that for depression, it can come on quicker. Dementia, it does take longer, months to years maybe. In depression, if there's a mental decline, it comes on quicker and it happens slower in dementia. Now, these, of course, there are going to be cases where it happens quicker, depending on the dementia or depending on what the personal situation is. This is just to give you a general overview, a more simpler way of catching it. But there are always outliers, right? And there's always overlap. This is a very difficult, this is why I'm going to be talking today about just some really basics for you to go on and learn more about. I'm going to have these in the handouts, and from this, you will hopefully do some more studying and more learning. So in depression, there's trouble concentrating. And dementia, you probably have that, but there's a lot more. It's mainly short-term memory. And in depression, you might notice that you recognize that you have some memory problems, but in dementia, a lot of times people don't recognize that they have memory problems, or now they're starting to hide them. So what are some next steps? Well, next steps are meeting with physicians for medication consideration. Always that first. Maintaining your, continuing to maintain your physical situation, your, looking out for those coexisting illnesses, getting support. So here's where I want to tell you, as a social worker, what I've noticed, one of the biggest considerations for people is to get help from a support group, a social worker, or a counselor. Persons who live with dementia persons who are diagnosed with dementia should automatically be offered this, and family members as well, because they will have a lot of questions, a lot to talk about, and they may not have a friend or somebody that they feel comfortable talking about with. A social worker who's trained, and what are the themes that this person might want to talk about? What are the things that maybe they want to bring up and they don't know how to bring up to their family members? Those are the things that a person with dementia, these would be the next steps. And certainly also beginning a plan for, what are the legal considerations they need to start be reviewing. Is there health insurance available? What do I need to make sure is available in terms of where am I going to live? What are some healthcare legal, POA, all those things, which include, legal documents that allow power of attorney, allow others to step in if it's needed. What are going to be the purposes of counseling? Well, support in facing the diagnosis, information. You're going to want to have some information, and hopefully you'll be seeing somebody that is informed about the diagnosis. Also, because it gives you a chance to receive kindness, respect, and attention. A lot of times people who have received the diagnosis have been in situations where they are embarrassed, they don't know what's happened, and it can be humiliating. And this is something that we can turn around by helping them see this a different way, treating them with kindness, respect, and attention, and helping them improve their coping ability. What are the benefits? Well, here you see the benefits are, increased well-being. You're going to learn more about your knowledge of good self-care. We're going to help you adapt to changes in the abilities and lifestyle. And certainly a decreased isolation, no matter where they are, unless it's a particularly sensitive spot. Improved communication, more contact with others is generally recommended until later stages when persons start to have some confusion or need some distance or space. And that's going to be something that evolves and comes to the attention of the person who's living with it and the persons around them. And there are some special considerations about how to manage that as well. So next steps, find a support group. I'm going to have in the handouts and one of the resources, different places you go to support groups. Certainly, Charlie's Place is a great place to have a support group, and there are other ones. Next step, get education. Next step, be educated, learn how to work with persons who have dementia. For example, be patient, don't argue. We're going to talk about where you can go to learn some of those things as well. So now let's talk about delirium. Okay, so we know that it affects to 50% of hospitalized older adults. we talk about delirium, we're talking about disturbance in attention and awareness that is acute in onset. It comes on quickly, and it represents a change from baseline cognitive function. But for the diagnosis, you need at least one additional cognitive disturbance. I'm going to show you here the DSM criteria for that shortly, but I want you to first know that the prevalence level. Because when a person who has dementia is hospitalized, they are very much more at risk to delirium. And patients with dementia are especially vulnerable to delirium, but persons who have delirium in the hospital, it can also aggravate and cause a permanent cognitive decline. It can prolong hospitalizations. It can, because of something not being done in terms of a delirium protocol, it could cause them to be re-hospitalized. It can cause nursing home placement when maybe it was not yet needed, and it can cause death because of all of the accumulation of other medical issues that come up. So here we have the DSM-5 diagnostic criteria. DSM is a diagnostic and statistical manual that we talked about. I'm just watching my time here. I'm going to let you see that one of the major changes, and this is what you should be paying attention to, is that we call it a disturbance of attention. People will say, well, they're just not aware. They're, people who are lay people will say, and we will say it, professionals will say, we're going back to, there's a level of consciousness that is different. And this has been one of the changes with the DSM now. The change is that the focus is on disturbance of attention. There's a reduced orientation to the environment. It happens over a short period of time, usually like hours to a few days. And it represents a very quick change from baseline attention and awareness. And it can fluctuate during the course of the day. It can also have a disturbance in cognition. In other words, people can have a memory deficit. They can be disoriented. They can have visual spatial, abilities change, and their perception. But most important is that it cannot be explained by something that already a neurocognitive disorder, and it does not occur in the context of a severely reduced level of arousal, for example, like a coma. So there's a disturbance. There has to be evidence of history and physical examination or laboratory findings. We want to make sure that all the labs have been done, that there's been adequate history and physical examination, and that the disturbance is not, from a substance abuse intoxication or from a withdrawal. So we have to know that those disturbances are a direct physiological consequence. It has to be a consequence of another medical condition, like a substance intoxication or withdrawal. So to us, laypersons, family members, when we talk to family members, this is what it might look like to them. Their movement might be sluggish. They might have unusual drowsiness. The person with delirium might have lethargy. They may not respond to caregivers or family. To the person who's reporting that their loved one is changed, and this has come on suddenly, they're going to say that they seem out of it. They're going to say that they seem like they're in a daze. But they could also be calling out. They could have a change of sleep habits. And they could also have changes in moods that come on quickly. There could be a personality change, and they could have something that looks like depression. They could have they could have a short temper or anger, but also there could be a difference, and that they could suddenly start feeling elated. Most important, we want you to pay attention to that term of inattentive. What are some of the risk factors? Well, certainly older age is one of the biggest risk factors. Brain disorder, dementia, stroke, or Parkinson's, as we discussed. Any condition that results in a hospital stay. Persons who are admitted to a hospital, this is something that we want to be especially cognizant of, especially if they are in surgery or if they're in an ICU, if they've had a past delirium episode, if they've had vision or hearing loss, any kind of infection. Certainly, doctors are going to check on infections, sepsis, any of those things that are affecting their medical situation that could be causing delirium. They could have pain. This could be a result of polypharmacy. It could be a risk factor, could be sleep deprivation. So let's talk about what are the differences between delirium and dementia. Well, dementia is going to begin with a minor symptom that worsens over time. Delirium is going to come on within a day or two. So this a lot, but remember, this is something that comes on quickly. The family member will come to you and they'll say, they were just fine. I just talked to them last week, and now, or even just in a couple of days, everything has changed. Their attention, their delirium, they might have the ability to stay focused. They might have, it affects their ability to stay focused or to maintain focus. Persons in early stage of dementia, they're generally alert. Certainly this becomes, but someone with dementia is often, they're usually not more sluggish or agitated initially. That would be a change. But the changes in symptoms of persons with delirium, the symptoms can come and go several times during the day. And a persons with dementia, they usually have a time that is the best for them. In other words, it's like they might be better during certain parts of the day. A lot of times during the end part of the day, what we know is sundowning, that's when they're not doing as well and they're affected. And that's how it's different between dementia and delirium. But I'll have another chart here that will give you a better idea of that. So when I was reading about this, remember, I'm not a doctor. I'm aware of it, but that doesn't mean that I can't learn as much as I can. And I found this is a video that is very good. There are many YouTube videos that are very helpful. This is a video of an interview with Dr. Eli West from Vanderbilt. And he is a specialist on this. And what I especially appreciated about his review of delirium and how to treat a person with delirium was that he paid special attention to number one, to the family and what the family could, how the family could benefit the treatment team by giving information. And it was especially respectful of recognizing that the family might need to be there a lot more, helping the treatment team with information about past history, what the symptoms are, but also having the family member there to help orient the person, help stabilize them in the environment. And unfortunately, some of these environments might be the ED or a hospital that is strange to them. So he talks a lot about that. I'm going to share that with you in the resources, not the video, but where you can go to find the video. But this is what he talks about. He talks about always have someone with the patient. Basically, have the family member there. This is going to mean the family member is going to have to trade off, right? Daughter, son, wife, husband, caregivers are going to have to trade off to preserve their health. But it's going to be very important that somebody that they know, the person who is being treated, is there to help them. Include the family. But one of the things he said that is especially important is early mobilization. That means when this happens, immediately start getting them oriented as soon as possible. What can happen, and I'm not pointing it, but what can happen is that persons who are not trained in assessing older adults may not recognize this as a change because number one, they don't know the person, and number two, they might have a stereotype that this is an older person and this is, so they begin to normalize this. They say this is normal for them and the person is acting this way because they're older, they might have something else. And so then they start to put aside the possibility of delirium. That the good news is that changes now because we have good tools if the healthcare facility is trained in them. I'll show you those tools in a second. But very important, start mobilizing, get mobilized, get them oriented. If they're able to walk, we want them to walk. Certainly that's up to the doctor and the treatment team, but that's not something we don't want it to go too long without getting them up and mobilized. We want the family member or someone that knows them or they know to regularly assure them, keeping them involved all along the way. If they have glasses or hearing aids, very important that they have with them so that they're not confused because they're not able to see, and they might start seeing something that's not there because their vision is altered. And the same with hearing. They may not hear something well, and so something they hear could be taken as a threat because their hearing aids are not with them. We want to avoid as much as possible any restraints. Anything that is invasive, IV if it's not needed. This is up to the doctors. I'm not a doctor, but avoiding benzodiazepines unless they're having an agitated situation. And he talks, Dr. West from Vanderbilt talks about, he considers what he calls the doctor-jury. You want to treat the disease. It would be sepsis, infection, whatever it is, that medical situation. And he immediately starts to look at what drugs can be removed if they're not needed. Certainly very delicate situation, only the doctor should be aware of, but very important that the family members are there telling the doctor what the drugs that their loved one has been on. And they want to ensure that the environment is a calm environment. It's calm, respectful, things like, turning off the TV in the room, not keeping them in an ER with all that agitated pace, getting them someplace quiet and away where they can have some security. So this is one of the tools that I wanted to share with you. This is in your handouts, but this is what we call an adaptation. These are the things that healthcare facilities, hospitals are probably aware of, but it doesn't hurt. And it's an education for family members also and healthcare providers, like social workers, to be aware of in our continued learning about delirium and how we can help persons who have dementia who are at risk for delirium. First off, you see here, orientation protocol 3 times a day. Very important that the staff is educated. And I liked constantly what I was hearing about educating the staff, making sure the staff knows, making sure that staff is working as a team. Family members, remember, you're not the staff, but you are part of the team. So certainly make sure that family members feel comfortable giving information as part of the team. And staff members, making sure you want to invite family members to be a part of the team. Cognitive stimulation, mobilizing quickly to give cognitive stimulation quickly and regularly, up to 3 times a day. Too often, persons might say, well, they're having a situation, I'm going to give them time. And that might be something necessary for that situation. But what can happen is the client gets kind of dropped off that list of cognitive stimulation. So we've got to go back and remember to schedule back to have cognitive activities 3 times a day with a person. Also, walking or active range of motion, getting them exercising when they can, and minimizing use of anything that's restrictive or immobilizing. We want them moving. Daily delirium screens, and again, educational programs about delirium, what happens when it's superimposed on dementia. I know I've said this regularly, and I'm going to say it again. Our healthcare facilities may not invite us to be a part of this, so we want to remind them that we're there to be a supplement. We're paying attention. We want to be able to advocate, and we're aware of that they cannot be there all the time with the client. But if a family member or friend can be there regularly, your opportunities to have better outcomes for your loved ones are increased. This was a table that I found that was a comparison of of dementia, delirium, and depression. And you can see here, now when we talk about the differences, here's an easier way to see how it is across the different illnesses. For example, onset, as we said, delirium, sudden and abrupt onset. Dementia is usually what they call insidious, slow. It's usually not recognized. And depression varies. You know, it can come on slow, but it usually is slower in its in when we recognize it. Course, again, delirium is short. It has daily fluctuations in how the symptoms are shown. Dementia is chronic and progressive. We know that there's not a cure for it. There is a cure for delirium, and there is cures for dementia, for depression. Here you see the differences in attention, in the orientation, the memory, and the thinking. I'm not going to be able to go through all of this because it's a lot, but you will have this in your handouts. You see in the handouts, I have a whole bunch of handouts. I know it can be overwhelming, but I want to be able to save some time to go over a case review because you can see it. This is a little bit more detailed and centered on medical situations, but it gives you an idea of some of the screenings that are done for the different areas, the screenings that are done for depression and dementia and delirium, and I'll show you those screenings. It also has some recommended labs for healthcare, what healthcare providers are going to be using and what they're going to be doing in terms of neuroimaging and pharmacologic treatment. This is a two-page review of the differences. I liked it, but I didn't want to show it because I don't have the source. And I really thought to myself, do I want to show this? I'm not comfortable with not knowing the source, but I really hate not showing this to you as a tool. Before I send you the handouts, I will continue to look for the source of this tool because it's much more detailed and gives a very comprehensive review for the reader. So these are some of the scales. This is known to those of us in social work who use what we call the GDS. Whoops. You know, this is a quick, a lot of these are 3 and 5 quick reviews to give to persons that we are looking, we want to review of where they are. This is not the only thing that will determine if somebody's diagnosed as depressed, but it's a very good baseline. It can offer a baseline, how somebody is, and just being able to have some of these questions is also a good jump off point. I use this also to talk to the client about what are some of the things going on in their life. This is what we call the PHQ-9, and the scoring you'll see here. Once somebody scores a 15 to 19 is severe, a 20 is severe, and then there's a final question regarding suicide, which is the flag for us about what we need to do if a person does score as suicide. And this is known to many of you. This is a many mental status exam. This is something that we're taught to do regularly. One of the things I want to say about the mini mental status exam and some of the other tests is that when we work as a team in a unit, on a healthcare facility, in a nursing facility, it's very important that the persons who are administering these tests are all trained to give it in the same way. Because one of the things that we can see that does not allow us to have a baseline is if people are doing the test differently. And if we haven't spent the time to orient our staff, orient the rest of our team, then we might be getting different scores because they are doing things differently. Maybe they're giving more time, maybe they're queuing. There are just different things that we want to make sure that everybody is doing these screens the same way. And this is the ADA, the dementia screening interview. So this is the MOCA. This is one of the differences with the MOCA. This is a cognitive assessment test as well, but this has become more acceptable for use because this is a lot more sensitive to being able to show evidence indicative of somebody with MCI, mild cognitive impairment. So this is what we use. This test does take training. You have to go to the MOCA site and take the training. I don't know what the cost is, but I want to say maybe it's $100. I've looked at it. I'm about to take it, but this has been a change. So now there is a charge. But the benefit to that is that you know that people are hopefully all administering it in the same way. So that would be very important, I hope. This is something that healthcare providers are using in the ER, on a hospital unit, and it's a confusion assessment method. It's called the CAM. And remember, I'm showing you these things just so you can have idea. When somebody says, well, you know, we administer the CAMs and the family member doesn't know, well, what is that? And maybe they're talking fast because they're in a rush. But this will give you an idea, well, what are some of the questions that they were asking? Well, why is it that my loved one scored a certain way on the CAM? So these are some of the questions. You know, they might say, well, was there evidence of acute change? Did the patient have difficulty focusing attention? And so these are the kind of questions that your loved one is being asked when you hear that there was a CAMS administered for them. This is page 2 of the CAMS. Just remembering that to be diagnosed, it would have to have 2 things mainly to just to flag on these, and that would be the first one, if there was an acute onset, how sudden this came on, and the level of inattention. So these are some of the resources. These are some of the, I will be giving you an updated, I know I've gone through this really quick, you guys, and I can't see your chat. I'll look at that in a second, but I want to make sure that I get a chance to review this case review that AHRQ provided to us. So I will send you these, also being aware of the BEERS criteria. The BEERS criteria is an important tool for persons who are giving medications that have potential to have bad effects on older adults. And again, don't have time to review all that. I'm giving you the resources so that you continue to learn about this and that you review and look these up. These are some resources that are really, that I depend on, that are good for you to know as well. Obviously, of course, I'm a big Teepa Snow fan. Thanks to Alzheimer's Services that brought her here for their last educational conference. These are some that I'm aware of and I'm familiar with, and I'm associated with Polarity for Charity. And I've also in here in your resources, I also have for you the website for the clinical trials if you're interested in any of that. These are some crisis lines. Always remember 988, that is available to you 24/7. And this is what I was talking about when I was mentioning the clinical trials. So yeah, I know it's a lot of information, too much information. My point was to give you the tools to continue to learn about this and study it. So now I want to just review, got about 10 minutes. I know it's going to be real quick, but I want to talk to you about what I learned about in one of the case reviews. And AHRQ has a section of patient safety and network, and they will often review cases. There's something that's happened, and they will go back and give a commentary. But give you a case that is not that unusual, but they highlight one of these cases, and one of the cases is this. It is of an 85-year-old man. 85-year-old man who has early stage vascular dementia, fell on the sidewalk, fractured the leg, was fitted with a cast at a regional hospital, was given crutches and instructions for no weight bearing. His wife, he was admitted to the skilled nursing facility for physical therapy. His wife stayed with him most of the day during the first 2 days. Before the event, he had lived at home. He was independent in activities of daily living. He used distance and reading glasses and eye drops. Over the past year, he did have some non-disturbing hallucinations. For example, he was thinking about things on the lawn, bugs on the floor. He did experience some daytime sleepiness. On day 3 in the skilled nursing facility, before the wife arrived, he became delirious and agitated. He started waving his crutches around, threatening the staff that concerned them. The sheriff was called. Patient was taken to the hospital emergency room. Patient spent the first night of the hospital in the emergency room overnight. At least his wife and daughter were able to take turns being with him. Day 2 of the hospitalization, he was transferred to a hospital room and he was seen by psychiatrists. That night, he becomes more agitated, throws something at one of the staff members. On day 3, he's more lucid. He remembers what, and he tells the staff what he was thinking. And he's remorseful. Persons who have delirium can remember, can go back and remember events that happened. And so he's apologetic. The patient is recommended transfer to the Jerry Psych ward of the hospital. The wife agrees, but she doesn't really understand. She doesn't understand what this means is that she will not be able to stay with him. So at this point, the patient has now been immobile for 3 days. He's had constipation, he's had pain, and he's had mild dehydration. Next 2 days, the wife and daughter, they express concern and they ask for him to be moved someplace else so that they can be with them. They recognize that he is in a place that's strange and that he needs family with them. The psychiatric intern is called, and he explains to the family that this cannot be, and because the patient has been involuntarily committed, there's not going to be a change of placement, and they're not going to change his placement, and so the treatment is going to be considered. And he says that the focus is going to now be on his behavior and not his immobility. The family is very concerned. They talk to the supervisor. The supervisor says, we're going to go with what the psychiatric intern says. The family is very concerned. They call the PCP. PCP says, I'm going to have to go with what the intern says, but I will request that, that you be given the chance to stay overnight if that's possible. The ward nurse, the nurse on the unit, refuses the request for the family to stay. We know that in many units, this is not something that is possible. So family is very upset, and they are escorted out at 9:30 p.m. The patient continues to have nighttime agitation to the point that now he is in restraints. Now the medical students have come on the unit. This is all true story. The medical students have come on the unit. They do a mini mental status exam, but no one does an in-depth medical history or dementia evaluation. Anything more. We know that dementia evaluation, it is beyond the scales that we've been reviewing here. There are many neuromedical, neuropsychological evaluations that need to happen. So risperidone is given to control his agitation. Day 6, the patient becomes aphasic. He has slurred speech. He moans in discomfort. At this point, the family members are very mad. They've gone to hospital legal and talked to them. And they do agree that we can at least have the family members there more often to help de-escalate and give the patient a sense of reassurance that he is with somebody that knows him. So at this point, the patient's then later released back to a skilled nursing facility, and he now has a diagnosis of Lewy body dementia. And later in the skilled nursing unit where he is, the risperidone is discontinued several months later, and there's a new geriatrician attending to him. But since this precipitating event, the patient's now lost 40 pounds, has limited speech, and limited mobility. So the case commentary from the doctors in this describe that the case illustrates how mismanagement of delirium can lead to poor quality of life, an overall functional decline, and profound negative health outcomes. Throughout the case, the patient experienced significant delays in being evaluated. The review of the patient's medical history and symptoms should have been conducted. And it was also known that he had a Lewy body dementia, the team could then have realized that those kind of antipsychotics specifically risperidone, would not have been well tolerated. The hallmark signs that were available to everybody treating them were the variability in the level of consciousness, the disrupted wake cycle, all of these things. But if he had been given his visual and auditory, his glasses and his hearing aid, he might have been less likely to misinterpret what was going on with the staff actions. So this is just an overall view of what can be a significant situation if these things are the team is not working together or attended to. I'm going to look just really quickly at the chat. I know I went through this a lot. Sad situation about this. Carol Bailey, thank you, Carol Bailey. I recognize and respect Carol Bailey's information and experience as well. Thank you, everybody. So lots of information. I know I went through it quick because you know why? This is what I do. I say, I'm just going to stick to this. And as I start to read about it, I was like, oh my God, I've got to share with them this. Oh, I have to share with them this. So then this is typical of me. I'm going overboard. And if you can't tell by my hair and my lipstick, this is classic for me, is to go overboard and over the top. So, but the good news is that you will have this in your handouts. Again, just remember, this is a chance for you to continue to take this information and learn more about it. So we have like 2 minutes for questions. I'll turn it back over to you, Ellen.
Thank you, Gina. That was an amazing presentation. So informative. Thank you so much for sharing all of that with us. So I know you can see the chats. You can see all the comments. I've saved them all for you, so I'll send them to you. And just a reminder to everyone about the follow-up email. The handout from Gina will also go in that follow-up email, so be on the lookout for that as well. Let's see, Gina, we'll give people like a minute or two to see if they have any questions. More comments are coming in for you. Okay. Well, Gina, I think you're just that good. I think people don't have any questions because it was so thorough.
I think they're probably still reeling and they're saying, well, that's a lot of information, and it is.
Well, thank you so much. We really appreciate you taking the time out of your day to come and teach us and talk with us about all of this information. And it was wonderful. So thank you so, so much.
Thank you, everybody.
Bye, guys.